So this is part 2 of the cardiovascular section. Again, probably when you encompass all of the cardiovascular medications, conditions, disease states, probably the biggest section you're going to encounter as far as the clinical preparation that you'll need to do for the NAPLEX. So definitely really, really important, I think, to know cardiovascular really well. So we're going to talk about hyperlipidemia, so that elevated cholesterol. We're still focusing on LDL. That's typically the primary focus. We have had more of a shift towards risk factors, so that's basically patients, smokers, diabetics, overweight, using the risk stratification tools like the cardiovascular risk calculator that I showed you. I've also got another link in here as far as that goes, just to remind you of kind of the importance of that. We used to focus a lot more on LDL goals, and again, that's kind of gone a little bit by the wayside, and now we categorize statins based upon intensity and getting patients to goal on the medication, not necessarily the goal of reducing the LDL to a certain level. So that's kind of where we're at now with that LDL management, is looking at kind of risk stratification of the patients and not focusing on the LDL quite as much. With hyperlipidemia, you can have certainly elevated triglycerides, and the big risk with triglycerides is pancreatitis. So as those triglycerides get above 500 or so or higher, we definitely worry about pancreatitis, and we definitely implement treatment for sure in patients with triglycerides over 500. And the statins in particular don't do quite as good a job at lowering triglycerides as other agents typically do. So fibrates, so fenofibrate, gemfibrozol or Lopid, and niacin are a few agents that you'll see utilized for those triglycerides. Now that risk stratification, I think I went through that a little bit in talking more specifically about CAD and that sort of thing, but you can certainly see that we can do a lot about a lot of these risk factors. Age and things like that, obviously family history, we can't do anything. They're not modifiable risk factors. But certainly hypertension, working on lipid levels, obesity, smoking, all things, diet, all things we can help with potentially, either with the aid of medication and or lifestyle adjustments. Now that calculator, again, just got that information in here kind of for your reference. These are just kind of the factors that go into assessing that 10-year risk. And there's the links again. So the statins, remember these are HMG-CoA reductase inhibitors, and they lower LDL. And most of these, if you remember, are dosed at night. Some with longer half-lives, it's really not quite so critical. The theory's always been that we produce cholesterol at night, and that's really why we should dose these meds at night. But again, if they've got a longer half-life, like atorvastatin, rosuvastatin has a little bit longer half-life, dosing them at night probably isn't quite so critical. What is notoriously bad is adherence to these medications. So I'd much rather have a patient take it in the morning and remember to take it than frequently forget in the evening, which some patients do struggle with that a little bit. So again, I mentioned that intensity. So we use low, moderate, and high intensity statins, and I've got a list here coming up. So these are kind of classic examples that you might see presented in a case. So if they've got a history of MI, of atherosclerotic cardiovascular disease, significantly elevated LDL, greater than 190, diabetes, and 10-year risk greater than 7.5%, These are high-intensity examples typically. With diabetes and the age, they say they usually recommend moderate to high. And again, you want to look at that risk scoring and see how aggressive we want to get with statin therapy. Oftentimes you'll have patients that maybe don't tolerate some of the higher doses of statins as well. So maybe you've got a patient that struggles with atorvastatin 80 or 40. We can look to switch them to a different statin, which is certainly an option. And I'll kind of talk about some of those clinical quirks with doing that. But we can also reduce the dose. Certainly we'd rather have them on a moderate intensity statin that they can tolerate versus no statin at all. For lack of, clinical evidence and guidance, most of the recommendations are maybe at age 75 to look at statins and say, okay, does this patient have a decent life expectancy? Where are we at? And if they do, you're probably going to continue them, especially in the setting of secondary prevention. If we've had a heart attack or stroke, you're likely going to continue them lifelong, except maybe not at the end of life, within the last year or two. If we do have a limited life expectancy, we may decide to discontinue them. Again, kind of depending upon what's going on with the patient. But again, age 75, that's kind of the ballpark where I relook at, especially primary prevention. Say, okay, is this still appropriate and that sort of thing? And it's a tough clinical question to ask, and to be tested on that. It's really hard to test on that. When would you discontinue a statin? And a lot of times clinically in practice, we don't really know 100% sure if it's the right thing to do or not. So really important to think about that. Again, getting asked a question on that, it's a hard thing to decipher and determine sometimes. So there's kind of the classifications, low, moderate, high intensity statins there. I would definitely recommend knowing the common ones: atorvastatin, rosuvastatin, simvastatin, probably the most common. I do see pravastatin used quite a bit in patients that don't tend to tolerate maybe atorvastatin or simvastatin. And I'll talk about that a little bit coming up here, but definitely knowing and understanding those intensities and what we should get to, especially in the setting of, post-MI, where we want high-intensity statin. You got to know that atorvastatin 40 to 80 is high intensity, as well as Crestor 20 to 40. Now, some of those clinical pearls that I alluded to, highest intensity, if we need to be aggressive, we have to use rosuvastatin or atorvastatin. Generally, I would probably prefer atorvastatin as the drug I would pick first in somebody that hasn't been on one in the past. Simvastatin's got, kind of wacky dose restrictions and all sorts of different stuff. It's not that you can't use it, but kind of a few quirks as far as drug interactions and things. Atorvastatin does have a few that way too. We need to kind of watch for adverse effects and things like that, maybe myopathy, when we're looking at these agents. If there is concern about adverse effects, particularly that muscle pain, we can check a CPK to see if it is getting worse and maybe progressing to a rhabdomyolysis type situation, and or if we're trying to rule out, is this due to the statin or something else going on? And if the CPK is elevated, unless they've had, recent damage to tissue, a fall, injury, that type of thing, an elevated CPK certainly might be from a statin if the timing makes sense there. Rosuvastatin, most potent. So in the setting of really elevated triglycerides and really high risk for heart attack and things like that, we may see a situation where we need to use a fibrate like gemfibrozole and a statin. So, and these are generally contraindicated with each other. Rosuvastatin may have a little less, interaction with the gemfibrozole compared to a atorvastatin or simvastatin. So that might be a potential advantage of using rosuvastatin there. Atorvastatin, like I said, you really get good coverage of moderate to high intensity, fairly inexpensive. Again, that 3A4 does have some potential interactions there. It doesn't seem to be quite as bad as simvastatin, but certainly we need to pay attention to it. Lovastatin, that's 3A4. I don't see that one used hardly ever. With the pravastatin, rosuvastatin, if I've got a patient that runs into myopathy on atorvastatin or simvastatin, I might look to use a more hydrophilic statin, and maybe one that utilizes kind of a different pathway than 3A4, maybe has less interactions via that pathway, and those would be like pravastatin and rosuvastatin. Lipid monitoring, definitely recommended periodically because we need to assess adherence. Again, with the latest guidelines that we have, we generally tend not to focus too much on the LDL level as far as where that target goal is. Our goal is really to reduce levels, but we do still check lipids to help us assess adherence. Remember, I said adherence to statins is notoriously bad, so we need to think about that. I have had some patients, as far as myopathy goes, try CoQ10, and some have reported luck in reducing myopathy. I don't think there's really great evidence to strongly recommend it or anything, but just something I have come across. So some alternative options. So I've got a lot of patients, or a significant chunk, that are at high risk, and we've tried a bunch of different statins. And what do? Okay, so ezetimibe, that might help lower LDL, that might help reduce the risk of events and different things. And then we've got PCSK9 inhibitors. I wouldn't spend a ton of time learning them. These are super, super expensive. Honestly, I've seen them maybe once. I've seen Repatha be used. So again, I wouldn't focus too much on it. But I would focus on patients who have failed statin therapy. What exactly happened? Which ones did they try? Can we get by with a lower dose? Can we do some different things there with that patient? And that's really a background history and a digging into that patient medical history. Triglycerides, kind of talked about that already a little bit. So gemfibrozole, fenofibrate. So we do increase that risk of myopathy, do we increase that risk of potential rhabdomyolysis in using the fibrates with statins. Fenofibrate may be a little bit better. That's probably the first place I would start as far as reducing triglycerides. Niacin can cause flushing, so sometimes patients don't like that, kind of a redness in the face and uncomfortable feeling. This has been shown to kind of increase HDL or be good at that. Clinically, we don't have as good evidence with HDL raising as we do with LDL reduction in preventing events, reducing heart attacks, and things like that. Niacin can elevate uric acid. Important to remember that in gout. CHF. So here I'm probably more so talking about systolic CHF, which is now classically referred to as reduced ejection fraction congestive heart failure or chronic heart failure. So kind of some word salad there, but just wanted to be clear, mostly talking about reduced ejection fraction CHF here, or systolic heart failure. What is CHF? So it's really this inability to effectively perfuse the tissue, pump blood, that type of thing. From a lab perspective, you may see an elevated pro-BNP, and that's indicative of your body trying to eliminate fluid. Remember, BNP, or brain natriuretic peptide, stimulates natriuretic effect, where it's basically fluid promotion out through the urine. So in CHF, your body's trying to really stimulate this mechanism and kick fluid out, and that BNP or pro-BNP will be elevated. Shortness of breath, coughing, that fluid can really get around the lungs. Often, from a medical perspective, there is a challenge in recognizing patients with dual diagnosis of COPD and CHF, because it's really hard to tell what's doing what. Is that breathing issues from their respiratory issues, or is that heart failure issues from potential for fluid around the lungs and things like that? So, and a BNP can kind of help differentiate that. If that BNP is really, really elevated, we can probably likely suspect that any type of breathing, shortness of breath issues is more related to heart failure versus like a COPD. Fatigue, weakness, these patients really have difficulty walking, moving long distances. They get really tired over time. And then, of course, pedal edema, where you've got that swelling around the ankles and exterior limbs and things like that. Now, acute management, loop diuretics. Furosemide being the most common one that I see utilized. And we do escalate doses. Oftentimes you'll see patients come in already on loop diuretics, having a CHF exacerbation, and we need to get more aggressive. Now, with that increase in aggressiveness comes risk of dehydration and damage to the kidney. If we lose too much fluid, that's going to potentially hurt the kidney. So always a challenging balance. Oxygen, if we've got low O2 saturations, if we've got severe hypertension in the acute CHF setting, you may see nitroprusside. Important to watch out for cyanide toxicity there. Again, kind of depending upon that blood pressure and where we're at with that. If you push in the diuretics and you're not seeing much response, depending upon that blood pressure, if it's severe hypertension, again, you may see nitroprusside. If we've got mild to normal blood pressure and the patient can tolerate more blood pressure lowering effect, we may add nitroglycerin in that type of setting. To kind of stimulate, to kind of give that heart a jump start, a little bit of a kick, you may see dobutamine or milrinone utilized in that setting. Beta blockers in chronic management are indicated to help kind of reduce the burden on the heart, kind of help relax the heart. However, in acute CHF situation, beta blockers can suppress that heart and make things worse. So again, controlled chronic heart failure, beta blockers are absolutely indicated, absolutely a part of therapy, and we'll talk about that coming up here. But in an acute type event, that beta blocker, adding that in may actually do more harm than good. So as far as chronic management goes, and acute in some situations, loop diuretics, again, mainstay of therapy. Potassium-sparing diuretics like spironolactone has good evidence for helping improve mortality in reduced ejection fraction, CHF. And thiazide likes, you may see them like metolazone give a little boost in the setting of the loop diuretic not doing enough to kick off fluid. Now, when you add thiazides on top of loops, you really get a profound drop in potassium levels. So that is definitely something to be very, very aware of. We've got to watch out for low potassium when we're adding loops, thiazides on top of loop diuretics. Again, these drugs can drop potassium by themselves, but when we add them both in, just kind of mechanistically, they can really wipe out that potassium. Potassium sparing, so these can be kind of advantageous in that they raise potassium levels. So it might make a little sense to get a loop diuretic, adding on that potassium sparing we can maybe boost that potassium level, which the loop is wiping out there. Again, using diuretics, ACE inhibitors, beta blockers, all in combination, it's difficult sometimes to get to doses, target doses that we want to get to, whether that be 20 to 40 milligrams of lisinopril. It can be difficult to get to that due to the blood pressure lowering effect and patients feeling orthostatic, feeling dizzy, feeling like they have really low blood pressure. Digoxin, this can be used for symptomatic management of heart failure. I would say I definitely see it used more often in the setting of atrial fibrillation. So there's the loop examples. Definitely keep those in mind. Fluid loss, electrolyte depletion. Again, anytime you're using a drug to eliminate urine or eliminate fluid out of the body, it's going to go out through the urine and through the bladder. So that's going to lead to frequent urination. Huge complaint in our geriatric patient population for sure. And oftentimes, because of these diuretics, which oftentimes are very necessary, this can lead to patients being put on anticholinergic medications like oxybutynin, ditropan, to try to reduce that frequency. So very challenging management in trying to manage quality of life as well as maintaining a patient's CHF and fluid status. Aldosterone Antagonists, spironolactone, you gotta know gynecomastia. Man boobs is the side effect there. Have to remember that with spironolactone, as well as the potential to contribute to hyperkalemia. So if you've got a patient already, maybe a potassium level 5.2, 5.3, 5.4 or higher, that's somebody that you probably can't start an aldosterone antagonist in. As far as conversion, equivalency, often you'll see ballpark of 100 milligrams of spironolactone used with 40 milligrams of furosemide. And the theory being that can kind of even out the potassium depletion effect from the furosemide and give you a little potassium boost. And they can hopefully kind of equal out that dose. It doesn't always perfectly work that way, but just some food for thought. Thiazide Like, so in CHF, metolazone or Xeroxilin is probably the most potent thiazide or thiazide-like agent you're going to see used. True thiazides generally, like hydrochlorothiazide, more effective in blood pressure, not quite as potent at reducing fluid loss in the setting of CHF. Beta blockers, ACE inhibitors, I talk more specifically about adverse effects and things like that. With the setting of CHF, the best evidence we have, we do like to push those doses. And drugs particularly you'll see in CHF, specifically for beta blockers, metoprolol extended release or Toprol XL, metoprolol succinate, however you want to remember it. Carvedilol is also one that has the best evidence or better evidence in CHF, as well as the metoprolol succinate. Those are the two I most commonly see in the setting of CHF. Digoxin, I kind of mentioned that in atrial fibrillation. Again, keep an eye on changing renal function, symptoms of toxicity, GI upset, bradycardia. Rarely you may see some visual side effects if doses get too high. So other agents, Entresto is a newer agent. You may see this utilized in patients who are still having problems, still having issues, frequent exacerbations, frequent hospital stays in CHF. You may see the ACE or ARB switched to Entresto. And this is a neprilysin inhibitor. And what that inhibition can lead to is an increase in those natriuretic peptides, which promote fluid loss as well as vasodilation type effect. Really, really important education point. We need a 36-hour washout period with ACE and ARB. So if you're switching from an ACE and ARB to Entresto, we've got to have that washout period. And there's a significant risk of angioedema if you don't do that. Other effects, think of ACE and ARB adverse effects. Hyperkalemia, the angioedema I mentioned, lower blood pressure, all potential adverse effects with this combination. And ivabradine, or Corlanor is the brand name, bradycardia. So if you got somebody with a lower pulse already, this med is not going to be utilized. You're going to want to avoid that. There's some potential that it can cause atrial fibrillation or induce atrial fibrillation, so that's not cool. And also, kind of a unique side effect is some visual brightness in the visual field. So just a couple of agents you may see used kind of down the line if we've, tried and failed or had adverse effects from other agents. Drugs that exacerbate CHF, I've certainly talked about these and will talk about these in other sections of the webinar series. NSAIDs, sodium retention, they can increase blood pressure, not good for CHF. Calcium channel blockers increase edema. TZDs like pioglitazone definitely can exacerbate CHF. Avoid that agent if at all possible. Do not use for diabetes in CHF. Pregabalin, Lyrica, maybe even gabapentin can definitely cause some edema and weight gain and potentially exacerbate CHF. All right, let's get into stroke and TIAs, trans ischemia attacks. So types of stroke, so we got hemorrhagic, so that's a bleeding type of stroke. And when I talk about stroke, it's basically this lack of perfusion, loss of blood flow to the brain. And it can be caused by a few different things. Hemorrhagic's basically a bleeding issue where we're bleeding out of the vessels and not getting adequate perfusion. TIA is basically often termed as a mini stroke, and I think it's important to remember those. With TIA is often symptoms resolve. There's no residual effects from a TIA typically, versus a stroke may have lasting effects where we've got damage to a specific spot on the brain due to a lack of blood flow for a significant period of time. And that ischemia can be caused by a couple of things. So we've got local, that's like an atherosclerotic event, where basically fatty deposits in the vessels, similar to the coronary arteries, kind of get blocked off and cause ischemia that way. So that's actually up in the brain, those vessels kind of having plaque and getting blocked off. The second one is in atrial fibrillation, which I talked about in a separate part of the webinar. So atrial fibrillation, we get this fluttering, this inconsistent pumping of the heart, inadequate pumping of the heart that cause some pooling of the blood. That blood pooling can cause clot formation. When you have blood that stops moving, we form clots. And that clot can be shot out of the heart and basically up into the vessels of the brain, where it can get essentially clogged and block off an area of blood flow to the brain. And so that's kind of how strokes happen. But we're really going to focus primarily on ischemic, talking about the atherosclerotic events and how drug therapy might be different there. And in atrial fibrillation, that's where we're using warfarin. We're using the new oral anticoagulants in that setting. Hemorrhagic can happen due to blood thinners. That's a risk that we run in using aspirin and using Plavix and using warfarin. There is a potential for increasing that risk of bleeding in a hemorrhagic stroke or a bleed in the brain. Signs of stroke: facial drooping, one-sided arm weakness, slurred speech, confusion, vision changes, falls, really common things that can happen with stroke. So if you're reading a case, trying to answer a question, and you see some of these symptoms, it definitely might be indicative of a stroke rather than, a drug side effect. The odds that a drug side effect is causing one-sided arm weakness is pretty rare. It's probably more of a medical thing causing a stroke. Now, as far as acute management goes, TPA is a common agent you hear utilized, and these are basically clot busters. They break down a blood clot that's in the brain, and obviously the quicker the better. Just like heart attack or MI, the quicker the better. And that's going to give that tissue in the brain that's maybe been blocked, the sooner we can get perfusion back to that tissue, the less likely we're going to have collateral damage. Now, there are some exclusion criteria. So if a patient has a history of intracranial bleeding, hemorrhagic stroke, things like that, that's certainly a risk with using TPA. If they have an active bleed going on, if they've got elevated blood pressure, if they've had recent surgery, head trauma, elevated INR, other anticoagulants that they're on, these are all situations where that risk of bleeding is really, really significant, and we'd really like to try to avoid TPA. Interesting one of glucose less than 50. Well, certainly signs of hypoglycemia could potentially present or mimic signs and symptoms of a stroke. So if somebody's got a low blood glucose, we would definitely want to replace glucose first, kind of before deciding whether they have an active stroke situation going on, because it could just be symptoms relating to the hypoglycemia. Risk factors for stroke, very similar to our cardiovascular risk factors as far as those relating to a heart attack, things of that nature. You'll note that atrial fibrillation is certainly a risk factor for stroke. And in that CHADS 2 scoring, which I talked about in the atrial fibrillation section, it's an important thing to remember that a lot of these things, like hypertension and smoking and age, those all factor in as well. Prevention, so monitoring the modifiable risk factors. As far as using antiplatelet type medications, this is an important differentiator. You need to know what type of stroke a patient had. Did they have a cardioembolic due to atrial fibrillation? Well, that's pretty easy. It should be warfarin or, one of the new oral anticoagulants. If they've had a stroke from an atherosclerotic event, then the drugs of choice are Agrinox. And if Agrinox is not effective or not tolerable or costs too much, I have seen clopidogrel used as a substitute there. So again, definitely important to remember what type of stroke it is, because that's going to guide what therapy you utilize. Peripheral vascular disease is one of those disease states that, there's a lot in common as far as risk factors go with heart attack, with stroke, with atherosclerotic cardiovascular disease. They often go hand in hand with each other. And you can see, yeah, exactly, atherosclerosis, hypertension, clot formation, viscosity of the blood. Most often with peripheral vascular disease, how patients will present, they get this stinging or this tingling, almost like your legs falling asleep, if you've ever had that happen, which I'm sure you've had. And it's very difficult and very painful and very uncomfortable. And they're essentially not getting adequate perfusion to their lower extremities. So how these patients present is they will walk for 60 yards, 100 yards, depending upon the severity of their PVD. And the more and more that they do, the harder they work, the longer they go, the more this effect happens, because your body's trying to get blood flow to those areas, but your vessels are so full of plaque, buildup, and that we can't get that adequate perfusion to those areas. So on assessment of these patients, what you'll see is pedal pulses that are absent. So you can feel for a pulse down in the foot, and you can't feel it. And that's because there's a really poor lack of perfusion. And whenever we've got a poor perfusion to an area, we do risk infection and amputation, because we can't heal that area if there is an issue going on down there. Medications really aren't that effective in treating peripheral vascular disease. We really focus on preventing and targeting those modifiable risk factors. So that's blood pressure, statins, and aspirin, and clopidogrel, using blood thinners, as well as smoking cessation. Very, very common for peripheral vascular disease to happen in smokers, for sure. Other meds that you might see used or tried, Cilostazol, kind of a few clinical quirks. There are some 3A4 interactions with this medication. Is a boxed warning that it can exacerbate, worsen heart failure. So if a patient has CHF, definitely avoid this medication, which some of them definitely can have peripheral vascular disease and heart failure. Administration on an empty stomach. There is some potential with its mechanism that it does inhibit platelet activity and things of that nature, and kind of reduce the viscosity of the blood. And with that mechanism of action, certainly it could increase bleed risk. Pentoxifylline or Trental, not one I see used very often at all. And we really don't have great evidence that it's effective in helping our patients there. So a couple examples of meds you might see used for peripheral vascular disease, but bottom line, we really focus on those modifiable risk factors. ACLS, I did want to touch on this briefly. I don't think you need to be a acute care pharmacist specialist that knows ACLS inside and out, but I definitely think you should know some of the meds that are used in ACLS. So with a cardiac arrest, we're generally going to look at the initial step of doing basic life support, CPR, airway, breathing, respirations, looking at that. Compressions, 911, getting an AED if we have access to that. As far as our arrhythmias go, or issues with the heart that may happen, VFib and VTach, so these are shockable rhythms. And in this setting, we're going to utilize our AED if we're outside, obviously in an acute care type of setting, and going to be prompted and guided through what to do there. As we get a patient into a more acute setting or in an ambulance where we do have medications available, potentially, then if shock is ineffective in these rhythms, then we're going to do epinephrine. And every 3 to 5 minutes, if epinephrine AED shock fails, kind of a last line, third line ditch effort is amiodarone. Now in asystole or PEA, pulseless electrical activity, this is a non-shockable rhythm. And in this situation, we're just going to give epinephrine and continue CPR, compressions, breath, and monitoring with that AED or with EKG, whatever you have at your disposal, depending upon where the patient's at, and seeing if they get into a shockable rhythm potentially. Other agents you may see utilized: adenosine for supraventricular tachycardia or SVTs, atropine for severe bradycardia, where we need to stimulate and get that heart rate going. If patients cannot tolerate and or atropine is ineffective, you may see dopamine utilized to help boost that heart rate and get that going. I would encourage you to take a look. There's certainly, looking at Google, there's certainly plenty of ACLS algorithm type things. I suspect you may be asked the question because there's certainly medications involved there and what should and shouldn't be used. So I wanted to give you a broad overview there of ACLS and highlight some of the really important meds that you might see used.